Thank you very much, and thank you, Timo, for inviting me. And thank you also to my colleague Fergus. We work very closely together, and although I present these cases, we're very much a team, and that we feel is a really important part of our paediatric practice. Not just a team between ourselves, us two interventionists, but also our anaesthetists, our intensivists, and our radiographic team. I'm sure you all agree, particularly in this patient group, it's really important to work as a group together for the greater good of the patients. So I'm going to present just two cases, and I'm going to keep it rather short for time. I'll take questions at the end of each case, and you can comment or criticise our management or my management as we go along. So the first is this 9-year-old girl who had a sudden collapse with headache. And actually, she became rather comatose very quickly, and she was intubated and ventilated, and she had been on ITU since that collapse without being woken up. She had this scan demonstrating some blood in front of the pons and around the brainstem, and possibly a little mass, which was confirmed to be an aneurysm as well on the MR scan. Now, also on this MR scan, and I'll just put the DWI up, you can just see some signal change on the DWI in the brainstem, both bright on B1000, you say that, but dark on ADC, so confirmed small brainstem strokes, presumably due to the dissecting process. Now, she had a CTA, which I'm not going to show you, but I'll show you the angio, just so you get an idea about the lesion, and then I'll go on to what our thinking was and our strategy. So she has this very broad-necked aneurysm of the basilar tip, or sort of mid-basilar up to the bifurcation of the supracerebrals and the PCAs. It's got two blebs in it on either end, and quite a nasty-looking broad-necked aneurysm, sort of dissecting type aneurysm, you'd say. She had good PCOMs on both sides, and in fact, on that angiogram, you can see the whole circular Willis injected. Rather anxious I probably was on that morning. I probably injected a little bit too hard. So two big PCOMs on either side. So some people could argue that you could wake her up and assess to see what function she's like, given how poor she was before she went to sleep. But actually, I decided to proceed just to coil her and then wake her up after that. But I accepted it was going to be a rather tricky coiling. I'm sure there are people have got different ideas about how best to do it. I decided to use a stent and use a solitaire stent, which we routinely just use one antiplatelet with, that bit out of aspirin. So I deployed the stent into the PCA and then down into the mid-basilar, and then proceeded with a rather loose sort of packing to try and coil off as much of the aneurysm as possible, accepting that the solitaire stent won't really protect much of the vessel, as you could easily get coil loops going out through the cells. But actually I managed to do this with really biggish coils, and that seemed to do the job. And then we gave her aspirin on the table once I'd finished the coiling job, or halfway through the coiling. She actually did fine with that, and we did an MRI at sort of day 3 or thereabouts, which was this study here, confirming the infarcts again. Maybe this one's new, more posteriorly in the midbrain. The aneurysm was largely coiled. I was quite happy with that. She woke up very slowly, was hemiparetic, and gradually got better over the coming months. Eventually went home, and I got a lovely card with her going back to school at about the sort of 2 or 3 month stage. But we did an MR early because we expected this thing to come back and ensure it did. So this is the MR at 2 months' time, by which point there's a large amount of refilling of the aneurysm. Now there was a solitaire stent already there. There were thoughts about doing whether we should put another stent inside it. We were also a bit worried about putting a braided stent inside another stent, a solitaire in particular. So actually what I elected to do, or decided to do, was just to recoil that aneurysm. And so that's what I did. And this is the result post-recoiling, except there's a large portion of this, or a significant portion more anteriorly, which is still underpacked. So that's the recoiling. Again, we expected to come back, and it did. So this is at another couple of months further down the line, so 5 months after initial bleed, with more filling on the MRA. She remained very well at this point and is improving all the time in terms of her function. I decided to recoil again, and this is the pre-recoiling, and it's really this bleb around the right SCA which is filling. So that was the pre, and that was the post. It's very difficult coiling to get the coil to sit enough away from the SCA, but I managed to do it, I think, with a reasonable degree of confidence that it was safe. She woke up absolutely fine. But now what? I've recoiled it twice. I'm absolutely confident it's going to come back again. So the decision was what to do next. And discussed this widely amongst ourselves and also in the international community, and came up with the conclusion that there was only really one treatment, and that was to occlude her basilar just below the aneurysm, and this is what we did. So this is the pre-occlusion test. Pre-occlusion, I actually did this puncturing both groins, putting a balloon up first and making sure she had the excellent flow from the anterior circulation to the posterior circulation that I knew existed from my initial angiogram. It still did exist, and so then I coiled just at the base of the aneurysm where the more inferior aspect of the solitaire stent was, trying to keep the coils above the level of the anterior inferior cerebral arteries, which I've managed. I would have liked a slightly tighter pack higher up, but it just proved very difficult to stay in the right place. So I felt acceptable. And following just the 3 or 4 coils, I was able to stop the flow with good flow through the PCOMs, filling both superior cerebellars through the top of the aneurysmal section. She woke up great, which I was very relieved about, other than difficulties with the pseudoaneurysm, which took quite some time to settle down. So she was in hospital for about 3 weeks, eventually requiring a thrombin injection to sort that out. But in terms of her neurology and her aneurysm, things have remained nice and stable. So this is now at about 10 months, and in fact, just before coming out here, she had another scan the week before, and last week, and it has remained stable with no change. So I think there's been some shrinkage of the residual filling at the top of the basilar tip with that flow reversal going on, and we will continue to watch her very closely indeed, because this is an aneurysm which we can never not follow up. So that's the end of the first case. I'm sorry to have rushed through it. Does anyone have any points to mention?
I think this is excellent management of what is presumably a dissecting type of aneurysm. And I think in these types of cases it's important to realize where the highest density of perforators are. And you were able to actually fill very nicely exactly the portion which is very where there are very few perforators, actually just cranial to the ICA, but inferior to where we see the basilar tip. So therefore, presumably, like occluding this segment was possible without having any perforator ischemia. I think it's
yes, there's nothing new on this MR.
Exactly.
Nothing new on this MR. I haven't shown all the sequences yet, but she accrued that little extra new bit after I coiled the aneurysm first time around when she was acute, but nothing else since then.
Nice.
Yeah. I mean, flow diverting stent right at the outset would have difficulty with from an antiplatelet reason, and which vessel would you have gone into, and would it have solved the issue? I think probably I did the only thing that could have been done really.
From a technical standpoint, do you think that if you consider to use those MPPs to control where the coils are going to go, if you want to precise faster points that you can potentially try to, just because the technical challenge you had is very true, to try to stop exactly where you want it.
Yeah, I know exactly.
Sometimes those can establish a border for you, and then you may coil the rest.
Yeah, I mean, the difficulty I had in navigating was actually navigating through the solitaire. they never really, as we mentioned earlier on, they never really sit nicely against the vessel wall, slight kink or whatever. And even just the small Duo or whatever I used, Headway 21 or whatever it was very difficult to get up high enough through the stent. Eventually I did manage to get it there, but I don't think I would have got anything bigger to sit higher up. Lucky at the time as accepting what you say.
Just a question to the audience. Would anyone have thought about using flow diverter in these types of aneurysms?
It crossed my mind, Timo. But I think this was the right management, and I'll show you why I think you're right in my talk. So the problem is, where do you put it? And then I have some interesting histopathology in mind of what happens when you're crossing some of these branches and stuff. So I don't know that it would have worked. And I also, because there's a solitaire in place, the behavior of the flow diverter is also unpredictable. Dr. Gunas, comment on that, or?
Yeah, no, I thought about it after the first coiling, but I felt I'd give it 2 tries, or at least it ended up giving it 2 tries before I, in fact, even at the time of doing the second coiling, I knew I had to occlude it. I hadn't consented at the time. Needed a bit more of a workup.
But you still had the option to do, you could have done overlapping low coverage, potentially place multiple solitaires or multiple.
Yeah.
Which is something we used to do, and probably coming back now, since I think we're moving away from flow diverter at this location.
Yeah, just very difficult to ensure you're in the lumen. I agree. Put a balloon up and make sure you're in the middle of the stent. But it was very difficult to get through the middle of the stent, and visualization was very hard because of the coils. Oh, before the coils. Yeah, could do. Yeah.
The one option apart from like a flow diverter and like a stent, another option for occluding that you haven't mentioned, but is the old-fashioned way, and that's a surgical clip. You can't do the test and the occlusion at the same time. But the nice thing about putting a clip on is that you don't, when you coil, you occlude, you take up a segment of the artery, right? And you don't know what perforator's there.
Yeah.
I think
exactly.
We're probably okay in most of these situations, because I think whatever the pathology in the wall is that lets these aneurysms develop probably takes out the perforators that are there. But the nice thing about a clip is you can actually choose where you want to do it. The clip is, like 1.5 millimeters wide, and you can place it between perforating vessels and be quite precise about it. Unless you really want to fill up the whole segment of the vessel and completely exclude it, as opposed to just reversing flow.
Yeah. Now this is the surprising thing. We've done both. We've done surgical clip, and we've done coiled the aneurysm without a stent all the way down to the basal artery and occluded the basal artery, which also gives us a shorter segment of sacrifice. It is amazing that actually you get away with this now. So Timo is right. I think the anatomy is very favorable for us. Normally we are scared stiff of putting things in the basal artery, right, in fear of stroke. But in reality, that segment seems to be very favorable to sacrifice if you have to.
Yeah. And actually the flow reversal has worked really nicely in shrinking down the residual at the top. Although it's not completely gone, that's nice to see as well. I'll press on. So my other case, and I have others, but I'll just present this as my last one, is a 2-year-old boy who had a 2 to 3 month history of progressive spastic periparesis. So he actually deteriorated between his referral and actually the time we saw him and got him on the table to treat him, to a 2 out of 5 weakness of his right leg and 4 out of 5 weakness less severe on his left. Of note, which of course ties in with what we were hearing earlier on, he has a strong family history of HHT, and not surprisingly, he's got one of these lesions that we were seeing earlier on. So he's got a large venous sac at about the level of T5 or thereabouts, with dilated arteries and veins both above and below that point. A lot of distortion of the cord, with the cord virtually completely compressed over to one side, and a little syrinx below in two little pockets between the bigger varix and the slightly smaller varix lower down. So the supply to this perimedullary AV fistula, which I'm sure you'll all agree you're going to see on the next coming slides, comes from three sources. So there's the anterospinal artery contribution from above, which comes from the typical location above the pica on the left-hand side, through a plexiform section, and then down onto the top of the sac. Here, just seen on this slightly obliqued AP. He's also got supply from below, so there's a left T9, both on these APs, coming up through very tortuous vessels, and a right T11, seen on this AP, and also on this lateral. And just pausing for a moment on this lateral, this ascending portion just to the front of the cord, to the front of the sac, is exactly where the anterospinal artery also plumbs in, just to that point where there's a very short section straight into the sac. And we know that because Dr. Robertson, when he went in to treat it, put a mic catheter all the way up into the anterospinal artery from below to above, and delineated very, very accurately exactly where the AV junction was. So a very short sulcal artery off the anterospinal and then straight into the sac. And so we can debate this in a few minutes' time when I show you what happened, and we can maybe discuss it more. But we'd wondered about whether there was a surgical option. Our surgeons felt there wasn't. Then we wondered about what the most safest way of treating it was, whether it would be glue, which we heard from Timo, whether a coiled or even an onyx would be possible. We discussed also with the surgeons about any preoperative laminectomy to give the sac more space. We started him on steroids. He made a little bit of improvement, but in fact we chose coiling. And the reason why we chose coiling was the control of the procedure, because we felt any gluing would be very close to the anterospinal artery, except we've seen a very good demonstration of how it can be done. But we used coil, and this is the position at the end of the coiling, where there is still some flow from the feeder below up into the venous side, up into the ascending veins. From the feeder below, there's a little bit of flow up into the anterospinal artery on this lateral, and then also a little bit of flow into the sac and into the vein. And so that indicates how close the coil was to the anterospinal artery. And this made it even more evident here with the catheter in the anterospinal artery doing an injection, comes around right down to the coil. There was really very little to play between being in the anterospinal artery and being in the vein in the venous sac. And so Dr. Robertson managed to do that perfectly. But he decided to stop at this point where there was still a little bit of flow, but he felt that he'd reduced it enough. Maybe thrombosis will take over and do a bit more. So we continued the steroids. We gave him low mercury heparin. We nominally went for 6 weeks. We watched him closely. He improved a bit. We decided not to do any laminectomy. His improvement fluctuated to a certain extent over the coming weeks and months, but he actually overall continued to make some progress, and we stopped those steroids at a few weeks afterwards. So he came back to see us in clinic, and at which point he'd got a little bit worse. And that's when we decided to repeat his MR, which I'll show you in a few minutes, in a few slides, what it kind of looks like now. It didn't look too different when we saw him in clinic. But we decided also to get him in, do an angiogram, and to assess how much flow there was. And this is this angiogram that is about 3 months after his original treatment. He's still got considerable size of the feeding artery from below, shunting into the sac, through the sac into the vein, with no filling of the anterospinal artery contribution from above, seen like we saw at the end of the end of the last procedure. And so that was treated. That's the other feeder, and that's the anterospinal artery from above. And we decided to treat that on this occasion with a catheter up into the through the coils into the vein, coils into the first part of the vein above the sac, and then onyx to finish the job, just to bring onyx down and to occlude the last little bit. And this is the final angiogram demonstrating flow from the feeder from below, and nicely eventually reaching the artery above, refluxing up this anterospinal artery, which is probably the first time we saw it fully, indicating that we probably had this time to shut the shunt significantly. Now I do appreciate there's still some flow within the sac, and I'll show you what it looks like on the MR that he had done yesterday, in fact. But this is how he is now. So he was sort of grade 2 out of 5 and 4 out of 5, and going off his legs. And this is literally just taken just the other day in our cafeteria at Great Ormond Street, where he's clearly not walking normally with a rather spastic gait, but the fact he's walking and making progress is great news. So this is the MR that he had done yesterday, kindly sent to us by our registrar, who remains in London. I don't think it's sunny here. He has his syrinx has increased, but actually all the feeding arteries and veins have shrunk down beautifully. And that has changed since the preoperative second embolization, pre-second embolization MR. So that's an improvement. I think all that flow is now thrombosed in the sac, or will thrombose in the coming days. Obviously, we're going to need to watch that syrinx carefully. Some surgical management of that could take place, but he's doing very well clinically. Any comments? Yes.
Why didn't you go for total occlusion of the vein in the first treatment?
You mean actually, why did we do what we did eventually, go up into the vein high and then cap down? I think we hoped that more thrombosis would take place with the amount of coil that we had in place. But it didn't happen. We were a bit disappointed to see how much flow persisted, actually.
But that's the problem usually with these spinal cord things, right? It's the same actually with dural shunts also, that if you have still something remaining, it will not go away. I mean, it's wishful thinking. Did you check if the patient has HHT?
The patient that has a strong family history of HHT. I think I said that at the beginning.
That right?
Yes.
Very good. Good for you.
Yes.
No, I think we all know that when you embolize with glue onto your spinal artery, it's a matter of millimeters, but it can be done. And I think in this case, all you could have done is just inject the glue and let it go into the vein, as Patrick said. So there will be another way of doing it. I mean, there's nothing against coils. I think coils can help to slow down the flow, and then you could inject the glue on top of that. But I think the main message is if you don't take the whole thing, it's unlikely going to go away.
Yeah.
Carl, and what do you think is the cause now of the syrinx? I think the cause of the syrinx is actually a venous outflow problem now, and it's not a problem of the arterial or remaining arterial input. And the fact that now the syrinx may be increasing, could it be a problem of venous outflow?
I'd always assumed it was the cause was the mass effect from the coils. You don't like that?
No, I'm not so sure. I would think it's more venous outflow problem.
Mm-hmm.
Stephanie?
So one last question from that.
I'm always reluctant to tackle barracks intraspinal. I probably agree with you about the syrinx growing because of the mass effect. I would look for surgical resection in that pouch. We had an almost identical case, not in a child with HHT, but RASA 1. Mostly posterior spinal feeders, but extensive anterior spinal as well. Into a barracks, it's almost identical. I embolized as much as I could, and then the neurosurgical department resected the whole pouch. And that way it's gone, it's not recurring, and there's no mess.
You're a good surgeon.